Today, I have the privilege to be speaking with Dr. Richard Harris. Dr. Harris is a board certified internal medicine physician and pharmacist. He attended the University of Texas at Austin for pharmacy school and then pursued medical education at the McGovern School of Medicine in Houston. His passion is to help all people to be proactive regarding their health, especially with hormone and metabolic health. Furthermore, Dr. Harris is experienced life science consultant who has helped several pharmacy and medical startups navigate the healthcare market, especially from a holistic perspective. A true entrepreneur, Dr. Harris is a CSO of Nimbus Healthcare and the medical director of Script Health. Welcome, Dr. Richard.
Thank you so much for having me on the podcast. Really looking forward to discussing something we're both passionate about today.
Of course. Okay, so let's start this off. Holistic therapies and prescription medications, something that you talk a lot about on your Instagram. So you compare a lot of holistic therapies with prescription medications. I think in one of your recent posts, you compared curcumin on osteoarthritis, and we know it has anti-inflammatory, antioxidant, and chondroprotective properties. You have been trained now in the allopathic model, both in medical school and pharmacy school. So my question to you, Richard, is what prompted your interest and investigation into holistic therapies?
Yeah, it started back in college. So I remember in genetics, we were doing a family tree, and I had to look at what diseases run in my family.
Mhm.
And I realized that just about everything ran in my family. So I had diabetes, high blood pressure, stroke, colon cancer, dementia, Parkinson's, anxiety, depression, PTSD. And I said, okay, I need to do something about this.
Mhm.
And I started really learning how was the best way to protect myself. And I leaned into, the basics, nutrition and exercise, stress management, sleep. And I further lean into this when I get out in practice because being a pharmacist, I could really well put people on the right medication for the right person. And the people would keep coming back and they weren't getting any better. And I kept seeing the same thing over and over again. Right med, right person, person not improving. Right med, right person, person not improving. And that's when I realized that I had to get other people to lean more into the lifestyle aspect as well and shift their mindset. And a lot of them was because they didn't think it was research backed. They didn't think there was evidence behind it. They thought it was all hooey or magic or something else. And that's when I really focused on and became my passion, telling people, hey, all of this lifestyle stuff and some of these supplements, there's good evidence behind them. In fact, there's evidence for some things that we compare them to medications, as you mentioned. So I felt like people need to hear that message to get behind some of these quote unquote alternative therapies. I hate that word. A therapy is a therapy, whether it works or not. If it's evidence based, it's evidence based. And that's really became my passion and my goal.
It's so interesting you mentioned the right medication, the right person, because of course a lot of research is backed by pharmacy big pharma and industry, and it's also a lot of the natural supplements that we don't often see them in research because perhaps you can't patent them, right, and you can't make as much money in that domain. So essentially, what made you kind of take that step to look at supplements? Because for sure, in pharmacy school, you're taught, pharmacological intervention, and of course, they're helpful in so many ways. But what kind of made you start looking at supplements as a therapeutic approach?
Yeah, personally, I was always taking supplements. I remember being 16 and in the gym and asking, "Hey, you're huge and you're strong. What are you doing? What are you eating? How's your lifting program? What supplements you're taking?" And I remember the first two supplements I ever took were like most 16-year-old guys who are athletic, whey protein and creatine. Right. I think
Yeah.
that's kind of like the, gateway drug, so to speak, for supplements for a lot of guys or for a lot of athletes in general. And it really got me interested in, okay, what else can I do to optimize my performance? At the time, it was athletic. And then in college, it was cognitive because going through organic chemistry and then in pharmacy school, And then in medical school, that's a lot of tough cognitive load and on academics. And so I really leaned into how can I enhance my cognitive performance at that time period. And then people often delineate, supplements versus medication. I'm like, they're all medicine. It doesn't matter. The term supplement versus it's arbitrary. In pharmacology, there is no difference. They work on receptors, they work on cells, they work on they're cofactors, whatever, you name it. And so I removed that delineation and I said, okay, I learned a lot about medicine and physiology or medications, pharmaceutical medications and physiology in pharmacy school. Well, I know there's a lot of natural substances out there that have similar mechanisms of action and maybe more affordable for people. Let me turn into learning about this. And that's really what drove me to be really interested in supplements, because I just love pharmacology. I love pharmacokinetics. I love pharmacodynamics. I love physiology. And that's kind of the intersection right there is supplements sit at the intersection of physiology and all of those pharmacodynamic and pharmacokinetic principles.
Now, so do you work with patients right now, or what does your practice look like?
Yeah, not as much as I used to. I still see some of our patients at Nimbus Healthcare, more focused on pharmacogenetics. So we have a hair program that utilizes genetic SNPs, and then we custom compound a topical solution for whatever your genetics say would be most optimal. I also see some of our men hormones patients. So we do, TRT without prescribing a lot of testosterone. We use like supplements and clomiphene, HCG, that kind of stuff. So I see some patients that way. But mostly what I do is building these businesses, Nimbus Healthcare and Script Health. And occasionally I'll still see some patients at a big box office. The
Mhm.
reason I do that is because I know most of these people will never have a doctor talk to them about lifestyle, about nutrition, about exercise, and really truly evaluate their risks. I think most of us, and by us, I mean, physicians, we look at stuff and say, "Oh, that's in the normal range. You're fine." And normal range is not optimal range. And
Mhm.
so, I know that a lot of times I'm the gateway for a lot of people to think about health differently. And so that's why I still do that job every now and then, just to try to get more people to shift their mindset and what they think about health.
Yeah, you mentioned something so impactful in that when I'm working with patients, they often come to me and say if they've had lab work done by their doctor, "Oh, my doctor said it was normal," and then I always have that conversation. There's a difference between normal and optimal. So, Richard, perhaps you can define normal versus optimal when it comes to lab markers and biomarkers for our viewers.
Sure. So I'll use one for example. Well, let's use blood glucose, right? So if you look at blood glucose, most labs are going to tell you the normal range is 70 to 100, right? And that's normal. Once you get above 100, now you're impaired fasting glucose or pre-diabetes or insulin resistant, whichever term you want to use. But we know that risk actually starts at the high end of the normal range. So once you start hitting above 95 consistently, yes, you're still within population normal, right? When you sampled a whole bunch of people without diabetes, what are their blood sugars? Well, this is the range it's in, but that doesn't mean that at the high end of that range that there isn't risk. We see this in things like blood pressure, right? You go to your doc, your blood pressure is 130 over 85. They're gonna be like, okay, you're pre-hypertensive, you don't need medication, but you're still at increased risk. We know
Mhm.
once you're above 120 over 80 consistently, your risk goes up for cardiovascular disease and kidney disease and all of those things. So there's a different way of thinking about, okay, how do we ensure that I'm in the optimal range, that I'm not at risk? I feel like my job as a physician is to mitigate as many risk factors that you have for disease as possible, and not
Mhm.
just say, oh, things are normal. So that's a lot of docs who are more holistic like us. That's the way we approach it, is to try to get rid of or mitigate as many of those risk factors as possible and not just rely on a reference range. And the other thing too is symptoms matter a lot. And so if someone tells you, hey, this is the way I'm feeling, and even if their like testosterone is 400, which most people would say is normal, right? It's in the normal range. If they're having symptoms of low T, I'm not going to say, well, your testosterone's normal, I'm not going to treat you. No, I'm going to try to get that to more optimal, 600, 700, 800, see if their symptoms improve. And if they improve, great. If they don't improve, then okay, let's see what else it may be causing these symptoms.
How do we define optimal? Because we have these ranges set forth by all the lab companies where they measured a whole bunch of people, and that's kind of where the ranges were. But for instance, vitamin D. I know we work with different measurements, of course, because I'm in Canada, you're in the States. But for instance, our ranges are 75 to 250, and optimal range might be around 150. But how do we establish the numbers for optimal?
hmm Yeah, that's a great question. And to me, it's looking at data. Where does the risk start? Right. So there are lots of studies on all different kinds of markers. We know for body fat percentage, where's the optimal amount to lower your risk of all cause mortality. All cause mortality is people who died during a study period versus people who didn't, and the risk associated with that. We know things for like triglycerides. If your triglycerides are above 100, that's when the risk starts. And there's studies on that. There's data on that, even though the normal range goes up to 150. Right here in the States, if you're above 100, that's when your risk starts. So that's what I look at. Okay, where does the risk actually start in these studies? And then with vitamin D, there is some evidence around, to me, and different practitioners are a little bit different. And I think that's because people have vastly different responses to supplementation with vitamin D depending on their genetics, right? So to me, I want everyone around at least 50, right, as a minimum. And here in the States, 50. Here in the States, deficient is 30, and no, deficient is 20, and then insufficient is 30, right?
Mhm.
So 50 is the number that I want to get people to, somewhere around there. Maybe it might be somewhat higher in some people. Let's say they live up north, and I know for like a long period of time, like you in Canada, there's a long period of time where you're not making any vitamin D
Mhm.
because the angle of the sun. So you may want to shoot for somebody who has a higher vitamin D in that situation, just because they're not going to make as much from sun exposure. So there's clinical studies, and then there's practical experience, and then there's individualizing recommendations to patients. And that's why this is truly an art, what we practice, because you have to be able to integrate all three of those areas to better serve the person that's in front of you.
Mhm. Your Instagram essentially provides viewers with 90 seconds of lifestyle medicine research. Your content, I find it so useful, and I'm sure so many people do as well. However, in the age of information, which is both incredibly powerful and resourceful, come the pitfalls of both misinformation and disinformation. So, Richard, first and foremost, what is your advice to doctors and or healthcare practitioners when they're scrutinizing research, and ultimately to see if the research is perhaps biased, valid, and free from conflict?
Yeah, absolutely. So the first thing you want to look at is, well, there's a lot to look at, but one of the first things I look at is the demographic, the population. Who was this studied in? Right? Because you can't just take a study that was, let's for example, nootropics, right? I hate that term. And the reason I don't like the term nootropics is because a lot of people are saying, oh, this helps cognitive health, but it helped it in people with Alzheimer's. That doesn't mean it's going to help it in people who are 20 without, any type of cognitive impairment. So you
Mhm.
can't extrapolate that. You have to look at, okay, let's say I'm 20 and I want to take something to boost my cognitive abilities. I have to look at studies that studied that in people who were like me, not people who had Alzheimer's. So that's one of the things I look at. Of course, I do pay attention to the funding, but I don't just dismiss a study outright because of who funded it. Right? You just have to take that into concert that there might be a little bias there, and you can see that in how they ask the question. Right? That's so important of the hypothesis. What question did they ask, and then what method did they use to try to get the answer to that question? Because if you have a study that's asked a certain question and used a certain method, then you may know, okay, I know you were trying to make this look better than it really is, right? Um, That's something I look at. When I look at drug trials, this is something that most people don't do. I calculate number needed to treat and number needed to harm. So,
Mhm.
number needed to treat is how many patients do you need to treat with this before one reaches the outcome that was studied? And that's very important because if your number needed to treat is 100, then I'm giving you a 1 in 100 chance that this actually works for you, right? And if that's the only thing I'm doing for you, that's not good medicine. That's not serving the person that's in front of you. And then, of course, the number needed to harm. If a drug is going to harm more people than it's going to help, I have to be really selective on who I put who is put on that medication. I look at absolute risk reduction as opposed to relative risk reduction. There's a lot of trickery in studies where they post relative risk reduction, which is a risk ratio, a risk in one group compared to a risk in another, which is not what people, when you hear 20% reduction, people think, oh, that's actually if there was, 20, if it was 40 people out of 100, now it reduced it to 20 out of 100, right? That's an absolute risk reduction, but the relative risk reduction would be 50%, right? Because
Mhm.
it dropped the risk ratio by half. And so what's get reported is 50% reduction in symptoms or outcomes or whatever. So that's something that you have to be careful with. And then the biggest thing is it in line with other research, right? Because you can find an outlier study or some cobbles together some mechanisms and say, okay, this is dangerous because of these mechanisms. Okay, well, let's look at outcomes, right? Because that's what really matters, real world outcomes. For example, you can look at like almonds, right? Almonds have cyanide in them, right? And so if you had told people, oh my God, there's cyanide in this, that's horrible. Cyanide can kill people. Yeah, in
Mhm.
high enough doses. But let's look at outcomes and studies of people who eat almonds. They're generally favorable, right? So you just can't take a look at one study or one mechanism and say this is what the end all be all. Take a look at the totality of evidence. Look for things like meta-analysis and umbrella reviews. Look for outcome studies in humans. Those are the main things that I focus on. And you talked about my page. You never hear me talking about a rat study, like,
Mhm.
unless it's really, really, really interesting, but I'm mostly talking about human outcomes because that's the things that are gonna determine what we do in our daily life.
Mhm. So, I mean, there was a lot of course, medical jargon, which of course I understood. But what about lay people who perhaps come across a plethora of data online? How do they know who to trust, or when they look at a source, for instance, how they can perhaps use that in their own life, or seeing that it's right for them?
Yeah, I think the biggest thing is number one, who is telling you this information, right? And looking at their credentials and their background, because that matters. If you don't have the right background or the right credentials, you can't evaluate this correctly. So if some dude on the street is telling you he's got the secret to longevity and you have no idea what his background is, you probably shouldn't believe what they're saying, right? Um, Another thing is there's fantastic resources out there nowadays because we live in the era of AI that
Mhm.
can pull together information for you. So consensus is one of my favorites, and you can type in anything. What does the evidence show about taking whey protein? And it'll boom spit out something for you, right? Examine.com is another one for supplements. You can go to examine.com, type in a supplement, and it gives you a list and a rating of evidence for that supplement in certain conditions. So what we always talk about in science is don't just blindly trust, verify, and have places that you can go to verify information. I think consensus and examine are great places for that. I think also be careful of the language people use around things. Is it like marketing type of language or is it scientific type language? It's kind of backwards because experts often talk with uncertainty and people who are in Dunning-Kruger, people who think they know a lot but don't know a lot, talk with absolute certainty on
Mhm.
things. And so those are some of the things I think you can pay attention to. And even if you're not well versed in reading studies, like some of the things that we talked about, what population was it in? Was it in humans? Is this in line with other studies or other headlines? Is this in line with people who have credentials who are reputable in that space? Um, a lot of the evidence-based community, they all hang out, they all do videos together, they all talk together, they all say the same things pretty much. So those are some easy kind of quick tips to get you in line about what information you're hearing and what you can believe.
Mhm. We did speak a little bit briefly about, a lot of the research is funded by, pharma or medicine, or by industry in medicine, right? And rightfully so, in that they need a lot of the funding to conduct the studies that they're conducting. But, simply stated, how can doctors trust data? Of course, you mentioned so many good ways to scrutinize data, right? But when we're looking at data that's funded by big pharma or the supplement that they're selling or the sugar industry, how do we look at that data and say, okay, I can trust this as a doctor?
Yeah, it's often that you can't just rely, like we said, on one study. Okay,
Mhm.
one study shows this. Okay, has it been replicated? Have these findings been replicated? If it hasn't been replicated, then you probably shouldn't stand on it like it's gospel. Is it in line with other scientific evidence, right? So what I'll do is I'll look at a study and say, okay, this is in line with other studies that are similar to this, maybe slightly different population, but they found similar things. And if you find, like, the holy grail is you find mechanistic evidence that supports it. So you find a mechanism for why that has an effect. You see observational studies that point in that same direction, and then you see outcome studies point in the same direction, and then meta-analyses point in the same direction. Right? So if that happens, then you can really trust what you're seeing as a result. If it's just mechanistic, then you can that's kind of, that's iffy, right? If it's just observational, if there's lots of prospective studies that all point in the same direction, that's probably believable. If the prospective studies are pointing in opposite directions, then you have to wonder, okay, what population and what questions did they ask? And you really got to dive in and try to figure that out. And did they control for the right factors, or did they not? Right? Did they select people who were too old or too young, or whatever? You have to start asking yourself questions and then take the results in the frame of those questions. So it's not easy. It really is a science to learn how to read and interpret science. But I think it's one of those things that as practitioners we have to constantly do, and something that a skill set that we need to teach ourselves and keep in our toolbox.
Mhm. And, typically, I would love to hear your thoughts about this. Typically in Western medicine, right? If it doesn't, or just medicine, I guess in general, if it doesn't have a double-blind RCT, it perhaps is disregarded as science, or we often hear the term woo-woo. A lot of the times, these alternative therapies kind of fall under that umbrella. What are your thoughts about this?
Yeah, so this is interesting. Um, a double-blind RCT tells you what works at a population level for a large group of people. It may not necessarily tell you what works for an individual, right? And so that's something that I keep in mind, because even all agents in, double-blind RCTs, there's some people who it just doesn't work for,
Mhm,
right? And there's some people that do. And how do we determine who is who? I think that having that is great. Having studies that are not controlled, then I think you can use that information, but you have to tell people, hey, this may not be any different than placebo, right? Now, here's why I think for you this would make sense. There are mechanisms or animal studies that show this kind of thing. And now we have some human evidence supporting its use. So I will, as long as there's toxicology information and it appears that we're not going to hurt people doing it. If there
mhm,
are people who want to try something, I'll say, hey, here's where we are with the evidence. It's not the best evidence. It's not the most well supported. I don't feel strongly about this recommendation. And I would say something like, it may not help you, but I don't think it's going to hurt you. And so I'll put qualifiers around that type of thing. Now, as we gather more evidence, great, that's better. But I think we shouldn't just outright dismiss everything that doesn't have a double blind RCT we should just look at it in the totality of the evidence that we do have, and then look at the demographic of the person who's in front of us asking us that question.
And as you kind of spoke about, that's the beauty of holistic, individualized medicine, right? Which in Canada here we have our public healthcare system, and it's of course amazing, but a lot of the times it's very impersonal, right? You go and see a doctor, and your visits are 5 minutes, and it's great for acute care, of course, but for a lot of the illness that plagues North America, chronic illness, it's very difficult to tackle in such a short amount of time. And going back to the research, if of course it doesn't have an RCT, having that transparency with your patient, and of course that first, Hippocratic oath of first to no harm. Whereas if you're trying to help the patient and you're not going to harm them, it's always warrants that conversation. Richard, what does practicing good medicine mean to you?
I think it's putting the person in front of you in the best place to get a good outcome, right? It's not ensuring a good outcome because, none of us are God. We have no idea what happens. It's just utilizing all the information that we have in front of us, what the person's telling us, what the lab work is telling us, what the data is telling us, and synthesizing a plan to give them the best chance to succeed. That to me is good medicine. Now, that could look different for two different patients. If someone says, hey, I know I have cancer, I don't want treatment, here's the reasons I don't want treatment, I just want to enjoy the time I have left. And then you say, okay, well, I support you, and what can I do to help you on that journey? That's good medicine, right? For another patient, it may be, hey, I want to do everything I can, doc. I don't care how experimental, as long as it's not going to make things worse. What do you got for me? Okay, I'm going to do that. We'll do some research. We'll talk to some people. We'll put the plan together. That's good medicine for that person. But it's really having the skill set and the knowledge to be able to play in both of those different sandbox. I think that's what makes a good physician or healer or practitioner, whatever term you want to use.
Yeah, and you highlighted, I think, such great examples when you mentioned, a person with cancer perhaps coming and saying, I don't want any treatment, etc., and you supporting that. It's a lot of people can very easily see that as bad medicine, but if you have that conversation with the patient and that's what they truly want, and you're there to support them, I would agree with you. That is practicing good medicine, right?
Yeah, absolutely. You have to go in line with what patients' values and what they want. If I talk someone into getting dialysis or starting dialysis because I think that's what's best for them, that's not good medicine. I've seen that numerous times where patients got interventions because they got talked into it and then regretted it, right? So the essence of being a good doc is informed consent. Really, truly giving people informed consent, supporting them in their decisions that they make when they are truly informed. Now, I think we do a really poor job of overall of giving people actual informed consent, laying out the pros, the cons, and giving them multiple options. I think a lot of people will just give the person what option they think is best, and that's not what we're supposed to do. We're supposed to give all the options that we know of that are evidence-based and can support that person, pros and cons of it, and then let that person decide on what's best for them and their lifestyle and their values.
Yeah. And so as healthcare professionals, kind of shifting gears a little bit, we always have to be doing, continuous education, consistently educating ourselves with research, technology, advancements in medicine. So let's go back to kind of what you do so well, and that is, scrutinizing research and informing the public of so much good research that's out there. Can you perhaps highlight a couple of research studies you have come across where you might have been, surprised by the results, stricken, or even elated by what you saw? And it could be for this question about anything.
That's a good question. I think one of the things that I've recently really liked were the results of the Cosmos trials. And it wasn't the main analysis, it was a sub-analysis on cognitive health. So a lot of people online would say, well, you don't need to take a multivitamin. There's no reason to if you're eating a balanced diet. And I'd say for a lot of people, that may be the case. You may be able to get along and do well, but you may not be optimal because a lot of us have, subtle genetic mutations where I may not absorb as much B12 from my food, or I may not convert vitamin D, as much vitamin D to the active form as somebody else, right? And this is not enough to cause an outright disease, but it may be enough that I can't function optimally. So a lot of people online will say, well, you don't need a multivitamin. And I love the results of the Cosmos trial, which were in middle-aged adults, which showed that people taking what I would call not a very high quality multivitamin, it slowed the progression of cognitive aging, right? And that's really amazing because dementia rates are supposed to triple Alzheimer's dementia by 2050. So something as simple as a multivitamin slowing down the rate of cognitive aging across 3 different trials, and then the meta-analysis showed that as well. That was really excited about that. And so now I take a multivitamin a different stance. I say, number one, are people going to be harmed by a multivitamin? Probably not, right? The risk of harm it's not zero, but it's pretty low, right? What's the cost of it? Even a high quality multivitamin is going to cost you like $17 a month. It's dirt cheap, right? It's like a nutritional insurance plan. So in case you don't eat a lot of certain foods, or you don't absorb certain or biotransform certain things well, it gives you an insurance plan. So when you start looking at it like that, I think that the evidence supports that it's reasonable for anyone to take a multivitamin. All right. I was really excited about that. I was really excited about a study that came out a couple years ago, I believe. It was a study that compared a meditation practice to Lexapro, and they found that meditation was non-inferior to Lexapro. That was really awesome because meditation and mindfulness is one of the hardest things to get people to start doing because they don't think it works. But then the people who do it love it. And they feel it almost immediately, that it can start transforming the way they feel, just because of, everyone knows that stress is bad for them. I don't think anybody can make it to adulthood and not think that stress is bad, right? But they don't believe that something like meditation or mindfulness can have the impact it does. And so that study was great, showing non-inferiority of a mindfulness intervention. So that means that practitioners can recommend to patients, hey, I have this drug over here, pros, cons. I also have a mindfulness intervention, pros, cons, and they were equivalent in this clinical trial. That's amazing. All right. And then I just posted, or I'm about to post one. I really I like minimum effective dosing, right? For everything, for medications, for supplements, and even for lifestyle. A lot of people think that in order to get the benefits of doing things like exercise or mindfulness or whatever, they just have to spend inordinate amount of time on it. So this study was a prospective study about stair climbing, and they found that people who climbed 1 to 5 flights of stairs in their home daily reduced their risk of all cardiovascular disease by 3%. So just think about that. That's a risk reduction just by climbing up the stairs in your house 1 to 5 times a day. Doing it 10 times a day reduced risk of cardiovascular disease by 10%. Wow. So the 10% reduction in cardiovascular disease, how long would it take you to do 10 flights of stairs throughout the day? I don't know, 2 minutes, 3 minutes, right? So that's a significant risk reduction in a very little amount of time. So I love studies now that are showing that even small bouts of exercise or continuous movement throughout the day have significant impacts.
Yeah, actually, that's kind of a new idea to me, that the minimal aspect of it, because oftentimes, as practitioners, we say start exercising, whatever, 40 minutes a day, 3-4 times a week, meditate, or have some sort of meditative practice for 10 minutes a week, and that for sure can be overwhelming. On the notion of exercise, there's something that I often recommend with patients. I don't know if you're familiar with it. Perhaps you can explore the research on it, but because I know it very loosely, and I'm probably not going to say it as well as I should, but it's something called exercise bite snacking. I don't know if you've heard of that. And so I always often utilize that with patients who perhaps don't have enough time to go to the gym for 45 minutes, an hour, where they can just do a couple of minutes on the hour. Can you speak to the research about that? Because I don't really remember what I read, and it was a year or so ago.
Yeah, it's been a while for me too since I read the studies on that. But if I'm remembering correctly, what they found was that people who did these exercise snacks throughout the day. So instead of working out continuously for 30 minutes, maybe they did a minute here, 2 minutes there, but the total time throughout the day was equivalent. They saw equivalent benefits. And I think there may have been a slightly more benefit to the exercise snacks than just to the longer duration once a day exercise. And that makes sense from a perspective of more movement throughout the day is better. I think that people tend to be like, "Oh yeah, I did an hour of exercise," and then they're sedentary for 9 hours, right? That's not the point. It's great that you're doing that hour of exercise, but it's also very good for our health to get periodic movement breaks throughout the day. I mean, the stats on just walking 8,000 steps, reducing all-cause mortality by 50, even up to 60, I think it's 62 or 63% in elderly individuals is absurd. That's astronomical, right? So, yeah, exercise snacks is great. I used to do those when I was in residency. Some
Mhm.
days if I knew I was going to be at the hospital for 36 hours, well, I'm going to do some push-ups. I'm going to do some squats. I had weighted vests. I had all that stuff with me. And whenever I could, I'd bust out some exercises there in the hospital. So it's fantastic that we can arm ourselves with so many different tools to meet people where they are.
Mhm. I'm personally passionate about holistic men's mental health. It's a big part of my private practice. So perhaps, is there any research that you've come across, to put you on the spot, in this area, which kind of stands out for you or that is memorable, where, again, from a lifestyle medicine perspective, where this patient population may benefit?
Yeah, there was a recent meta-analysis on exercise and depression, and I posted that online where they looked at various different forms of exercise and the effect size, which is what it sounds like. How effective is this intervention for reducing depression? And they actually found dancing was the most effective form of exercise for reducing depression. And previous studies in elderly have shown significant improvements in cardiometabolic health by dancing. And so I think there's a lot that the reason for that. One, it is exercise. You're moving your body. Number two, you're listening to music. You're with people. You're having a good time. Like there's so much of different parts of dancing that can be positively associated with health. They also found that strength training was very effective. Yoga was very effective. Jogging was very effective. And the effect sizes for all the exercise interventions were greater than the effect size of SSRIs, a class of medications for depression. So I'm not saying that SSRIs can't be helpful or medication can't be helpful for depression. They absolutely can. The thing about these medications that most people don't realize is two things. Number one, 33% of people are just non-responders for depression. Any medication you give them, they're just not going to respond. And the endpoint in clinical trials to get these medications approved is a 50% reduction in symptoms. So if I reduce 30% of people's symptoms by 50%, I can get my medication approved. Well, that means there's a lot of people that's not going to help, and that means there's people it does help that are only partially going to be helped. So we need other effective modalities that are have been shown to be effective for mental health, and exercise has been proven time and time again to be a very effective modality for mental health. And I think that's for several reasons. One, muscle contraction increases brain derived neurotrophic factor, which is like brain growth food, right? We know that people who have depression, Alzheimer's, a lot of other brain issues have lower levels of BDNF, and animal studies show increasing BDNF has positive outcomes. It's also doing something hard. And, when I talk about this, I say people are soft these days. We all want comfort. We don't want to do anything hard. We don't want to be inconvenienced. Well, if you continuously seek out comfort, you will make your life hard. If you intentionally make your life hard, your life will be easier just because you're better able to withstand it and resilience. So I think doing
Mm.
exercise is a sense of accomplishment that you did something, that you pushed yourself. And that we know a sense of accomplishment and purpose is very important for mental health and physical health. And then there's, the improvements in blood pressure and blood sugars and all of that plays into brain health. So that was a study on mental health I thought was really interesting.
I want to talk a little bit about something that you're probably very familiar with, the file drawer effect, which are you familiar with the concept, the file drawer effect?
No, I'm actually not.
Okay, so let me explain for what it is, and then I'd love to hear your thoughts about what it is. So essentially, the file drawer effect is the failure to publish research because the researcher feels that the outcomes perhaps were not positive, or because they were statistically insignificant, which inevitably this is a large publication bias. So from a research standpoint, I personally think it's so important that we make all research available, right? And we have to maintain the utmost transparency, despite what the researchers or the institutions feel. So that's kind of in a nutshell of what the file drawer effect is, and they just don't publish the data. Whereas a lot of the times they're only publishing the results that are favorable, I guess, to the hypotheses that they set forth. So what are your thoughts kind of around that?
Yeah, negative data is very important because it tells sometimes you need to know what not to do as well as what to do, right? And then it can help you tweak your approach because was the data negative because the intervention didn't work? Did we not ask the right question or did we pick the wrong population, right? Did we use the wrong measuring stick? Right. So you may have something that works and you just pick the wrong measuring stick or the wrong population, and then it gets set aside. And so that's not beneficial. Some other researcher could come up, read that and say, hey, actually, you should have done this. And I think
Mhm.
this may be the what you're looking for. And then all of a sudden, boom, now we show a positive effect. And you're right, it decreases publication bias. It's just better overall, enhancing the quality of research to know when things don't work and to know when things do work. And I think it was only recently the law was passed that they had to publish like negative research on like drug trials, m- if I'm remembering that correctly. But there's still a ton of older research that
Mhm.
on things that didn't show positive results that were never published.
Mhm. I want to talk a little bit about stress, because this is something that, of course, we can measure, arguably objectively and or subjectively, right? And I think medicine struggles a lot with things that we can't measure. As much as it is, as much as it is a science, it's an art as well, right? As you mentioned earlier. I think I was reading where stress, constitutes 80 to 90% of doctor visits through some estimates. Now, when I say measuring stress, of course, we can measure stress through, cortisol levels, heart rate variability, and perhaps like objective questionnaires as well. But, I think that there's no laboratory result or finding that can, deduce the entirety of the mental angst one experiences as a result of chronic stress and or emotional suffering. So I would love to hear your thoughts about what you have read in the literature when it comes to like stress, how it's been measured, because it's such a big hot topic. And I think in medicine, a lot of the times, if we might not know what's going on, we might just say, stress, right? So I'd love to hear your thoughts around that, Richard.
Yeah, stress is ubiquitous, right? You're always going to be stressed. We're in an environment where you're going to experience stress, right? And what I like to say about stress is I may not control everything that happens to me. In fact, I can control very little of what happens to me in a given day, but I can always control how I respond. Right? The thoughts that enter my head, the words that leave my mouth, the actions that I take, those are always under my control. So I focus on what I can control. William James has a quote, and I may butcher this, but he said the best defense against stress is our ability to choose one thought over another. And it's so true when you think about it. Um, Stoicism, I've been leaning heavily into the properties of Stoicism and how their philosophies on stress and being harmed. It's like you're only harmed if you believe you are harmed. If you don't believe you are harmed, then you're not actually harmed. And so it's just about controlling the mind and your thoughts. But yeah, stress is everywhere. Lots of people are negatively impacted by stress. And you're right, there is no one blood test. We can kind of see it in certain things,
Mhm.
right? Like you said, cortisol, people whose testosterone drops, people whose blood sugars increase, or their blood pressure may go up, heart rate goes up. People who you ask them if they were upset about something, what level did they respond to it? Oh, like a 3, and then they say, well, what level are you responding now? Like a 7. That might be due to stress, that their emotions are heightened and magnified. In
Mhm.
clinical studies, the most well validated thing, I think, or the most used one, is the perceived stress scale. That's typically what you'll see in studies when they are utilizing stress interventions and monitoring people's stress. Me personally, I like you, I track heart rate variability. I track my blood pressure. I track my heart rate at baseline. Exercise performance, because when I'm stressed, my exercise performance goes way down.
Mhm.
I can see that, and I can feel it, and I track my exercise performance. So there are lots of metrics that you can track, and then once you get really in tune with your body, I can feel it. When I'm stressed, I feel it. I feel different. I feel tighter. I feel more constrained. I feel like my muscles tightening. Like, I feel those physiological effects of stress, and then I'll do like some breathing exercises, or think about things differently, think about uh the pros in my life, things that are going well, have some gratitude, and I can feel that stress, like literally, like lightning, like
Mhm.
there's stuff being removed from my body or around me. And I think that's really, really important, and people know stress is bad, like we talked about earlier, but they don't see how that stress is affecting their lives, in so many aspects of their lives on a daily basis.
Mhm. Richard, I want to wrap the discussion here and talk a little bit about an initiative that I think you're part of. You're the CSO of Nimbus Healthcare. So, can you tell our viewers, Richard, what exactly is this Nimbus Healthcare or Nimbus Health Club? What's its initiative? What do you do within it? Just share it with our viewers.
Yeah, so Nimbus started off as a want to get precision medicine to the masses. So my business partner Joby owns a compounding pharmacy, and we know that compounding offers many different avenues that traditional pharmaceuticals don't offer. And we wanted to be able to get that to people who don't have access or don't have physicians near them that know about compounding. And so we started off with hormones, men and women. We
Mhm.
started off with hair restoration because of the genetic test. And then we also do compounded GLPs, right? And then I didn't want to just create another healthcare company giving drugs, even though we're doing precision medicine. So I created the Nimbus Health Club, which is where we can go in and talk about these aspects like we talked about today, the research on stress, the research on exercise, how to spot misinformation, how to pick a quality supplement, right?
Mhm.
These other determinants of health that people don't get talked to one on one by a lot of practitioners unless they own their own practice and they have the time to. I wanted to create a resource where, one, a community could come together, they could talk about their health goals, share their health goals, learn from each other, and two, get evidence-based information from practitioners that I trust and that I know. And so that's initially what we do at Nimbus. We've got some really cool initiatives coming out. Um, we believe in peptide therapy. We just think a lot of people are getting peptides from God knows where, right?
Mhm.
And that they're not being monitored safely. Peptides they're a drug just like any other, and they can have serious negative consequences if the wrong patient population is chosen. And so we're gonna do it in a safe way, monitor lab work and other biometrics um, that could indicate there are problems. Just because we do want people to have access to these therapies, but we want to make sure they can do it safely. So that's really our essence at Nimbus.
Mhm. And Richard, one final question, kind of to bring things full circle. What are your top three advice points for analyzing research?
Be open minded. That's number one. because sometimes you're going to read a study that's going to go against what you believe, right? Your
Mhm.
own biases. So you have to be open-minded. There's so many times where I wanted like a supplement to work in a study and it didn't. And I'm like, no, why? And you just have to go with that. Like that's okay. Number two is focus on the human outcomes. If you're new to the game, that's the most important thing. What are the human outcomes? And then the third thing is have a place that you can go to verify things that you hear or things that you read, right? And I think that's becoming easier again with those resources I mentioned earlier, that even if you are a layperson, maybe you go to PubMed, you look at an abstract, you don't know how to interpret it. Okay, go to these places where their job is to make this easily and accessible to people. There are other people who write research reviews, like Lane Norton has Reps. That's a research review where he reviews studies. Alan Aragon has one. So there are people who are scientists who have research reviews that you can subscribe to get their in-depth breakdown in a way that anybody can understand. So that's what I love about living in the modern age. Resources. We have resources on resources on resources, but you have to be willing to invest the time and effort to take advantage of those resources.
Yeah. So open-mindedness, human outcomes, and some sort of verification. Three, I think, amazing advice points to summarize, where a lot of viewers perhaps will find that quite useful. Richard, this discussion was amazing. We went on, this research inspired discourse where I learned a lot myself. And I'm sure a lot of viewers are going to take a lot of what you said and hopefully utilize it in their own clinical practice. Any last parting thoughts for our viewers, Richard?
No, I thank you so much for having me on this show. I always say keep learning, keep being a student, stay curious, right? Stay open minded, and you realize that being a healthcare practitioner can be a very rewarding and very amazing profession. Um, and that we're needed, and this approach is needed, and it's more needed now than ever.
That's a great way to end the discussion. Richard, thanks again so much for coming on the show today.
Thanks for having me on, George. I appreciate it.